So we're going to talk about cannabinoid hyperemesis syndrome today, which is one of the few true contraindications to using cannabis. I do have a conflict of interest in that Credo Science has originated a screening test for the genomics of this disorder, so I do have a vested interest. So this is the paper that came out of it, and we're going to be discussing this in detail subsequently after some introductory material. There's a link there. This is also open source, so you can access it on PubMed free or at ethanrusso.org at the library tab. First, what is this? So this was a real mystery. It was first described in 2004 in Australia in 8 patients, but the index patient, the first one that manifested symptoms, was clear back in 1996. So you can imagine going 8 years with this mysterious illness that nobody could treat. They nailed the description, because what they said now 20 years ago is exactly the description of the syndrome today, which is a combination of nausea, vomiting, abdominal pain, and hot water bathing behavior. And this was among people who had no knowledge of other people being similarly affected. So it wasn't a matter of one person saying, hey, if you take a hot shower, you'll feel better. So this is associated with cycles of nausea, vomiting, abdominal pain, basically abstinence from cannabis or CB1 agonists is the only effective treatment, but as we'll see, haloperidol or capsaicin on the skin may be helpful for an acute attack. Prior to our study, the biggest case series was in 98 patients at the Mayo Clinic. There was a review in 2018 that found 105 citations about this disorder, but it's more since. Probably the best article on its pathophysiology is Devono in 2020. She described a prodromal phase of nausea and vomiting and anxiety and sweating, followed by the more classic hyperemesis with all the accompanying symptoms. And then if a person abstains from cannabis, then recovery. There was a 2012 study that looked at the costs that people had incurred between emergency visits and diagnostic tests, all for naught, and that figure was $95,000 then, so you can imagine what it might be now. Unfortunately, there have been at least 2 deaths directly attributable to this. So it wasn't cannabis that killed them, but the syndrome did because of hyponatremia and accompanying problems related to the emesis. Interestingly, the standard anti-emetics, the 5-HT3 antagonists like ondansetron and granisetron don't work here. This is from the Devono article, and they had this nice diagram that I'm sure you can't read, but again, describing possible pathophysiology. As we've heard before, cannabinoids, including THC, can have biphasic dose responses, so everyone knows that a small dose of THC is good for nausea and vomiting and chemotherapy, but anyone can vomit from cannabis if their THC intake is too high. Additionally, if this is done on a chronic basis, there's a downregulation of the CB1 receptor where THC works. And under those conditions, THC can act as an antagonist and, again, might induce vomiting. A very prominent aspect of this disorder is activation of the hypothalamo-pituitary axis, HPA. And she had pointed out that there could be a genetic predisposition, but at that time, that wasn't defined, and this is certainly something we wanted to do. You will hear from a lot of people that this is due to pesticides or neem exposure, but that's totally unsubstantiated. There was this bizarre study in 2018. So This was done at Bellevue, the big public hospital in New York City. And among people who didn't present with CHS, they asked them about their cannabis habits and whether they had ever vomited and whether it was better if they took a hot shower. So they created their own definition of CHS. They estimated that 33% of heavy cannabis users might have this. If you extrapolate that to the US population, it would be 2.75 million people affected. Another agency estimated 350,000. I think that the truth is somewhere in between. An important point in this study in 2013, there was this 30-year-old guy, and he had a history of CHS based on the symptoms. He was a heavy cannabis user, but had a job where he had urine testing. So he stopped the cannabis, and this is an unfortunate common scenario, in favor of using synthetic CB1 agonists, for which they normally aren't going to show on urine testing. And he resumed having CHS symptoms. So he hadn't used cannabis for 6 months. They tested him. They did not see THC metabolites, but did see evidence of the synthetic cannabinoids. When he quit everything, he cleared his symptoms in 2 weeks. So this shows that it is a problem with hyperstimulation over the long term in the CB1 receptor. Now, this similarly can happen with delta-8, synthetic that people are making out of excess CBD as a way to make money. It is weaker as an agonist as compared to delta-9, but in this case report, this 38-year-old woman clearly had symptoms of CHS related to delta-8 gummies. And then this case that I really question. This is a 6-year-old who had seizures as a result of an encephalitis and had been on cannabidiol as Epidiolex, which is about 98% pure. There are vanishingly small amounts of THC in it. This patient had 5 episodes in 6 months of vomiting, lasting 1 to 2 days. They assumed it was CHS. There was one more episode after stopping, and then there weren't any, and they decided that this was related to CBD. I think that's highly questionable. We do not know if someone took absolutely pure CBD, whether that would trigger it. My suspicion is no, but everybody we've talked to so far has relapsed. And that's often because CBD is rarely that pure, particularly in the current environment. I got sick of hearing that various other things were causing CHS, whether pesticides or neem, so I wrote this editorial in 2021. This guy had the crazy idea that hop latent viroid caused it, despite the fact that not only has this virus never caused disease in humans, no plant virus has ever caused a disease in humans. So it was just a theory with nothing behind it. Neem oil is an organic pesticide. You can search very carefully in the literature, and you'll barely find any instances of toxicity from this, and the toxicity that is there is quite distinct from CHS, and that's true of its most active ingredient, azadirachtin. That is a very hairy molecule that you see here. It's got an extremely high boiling point of almost 800 degrees Celsius, which is about the temperature of a burning tip of a joint. So the idea that this might be turned into something else that's more toxic than azadirachtin itself is really far-fetched. So another myth. And this is just about pesticides. Pesticides are a huge problem where it's not monitored properly in cannabis commerce. However, the things that they do, like organophosphates and other agents that cause endocrine disruption or potential carcinogens, they don't resemble the symptomatology of CHS either. Now, back to our study. We hypothesized that this could have a genetic cause. And the reason for thinking this is we all know people who use great volumes of cannabis and have never had this problem, whereas others do. We thought that there might be mutations on a variety of genes. And our top candidates were the CB1 gene, CNR1, the TRPV1 gene that responds to heat and capsaicin, that would make sense, or that it had something to do with the breakdown, metabolic enzymes for cannabis, particularly THC. So this could be done with genomic testing. We had an extensive questionnaire that was developed to make sure that people had the diagnosis that was active and that they had a diagnosis already from someone. We wanted to make sure that people who hadn't been misdiagnosed and didn't have current symptoms, so they were eliminated. This went through an institutional review board, and we recruited over a year 585 patients. There were 205 that had had a diagnosis of CHS and had active symptoms. They were the ultimate study group. 99 of those agreed to get a genomic test kit, but this is where it got hairy. Only 28 returned them, and unfortunately, this was primarily due to active dissuasion from some people in the CHS community that questioned our motives in doing this whole thing. We also had 54 controls that were high-volume cannabis users that didn't have the symptoms, and 12 of those agreed to testing. Like it or not, this is the largest CHS study to date. This is the methodology of it. If you have questions about it, why don't you ask Kevin McKernan, because he'll understand it and I don't. So survey of the summary of the survey. There were 205 CHS patients, again, high frequency users, 91% daily or more, primarily using high THC preparations, especially flower, and an average of 4 grams a day, which is very high intake these days. Almost 16% had had a diagnosis of cannabis dependency or addiction, and over half had had withdrawal symptoms, which is not, that were significant to them, which is not common either. Almost 90% had symptoms improve after they stopped, but almost all had relapsed. For the controls, their use patterns were quite similar. Again, they'd all been recent users, 70% daily or greater, and smoking high THC predominant material, again, an average of 4 grams a day. So we really were comparing like to like. In contrast to the CHS patients, less than 4% had ever been labeled as being addicted or dependent, and 3/4 had never had withdrawal symptoms. Only 11% had been told to stop for any health-related reasons. Just a bunch of comparisons from the survey. A vast majority smoked. Again, 100% of the controls were current cannabis smokers. You can't see it very well, but on the right, that's a graph of daily intake, and the big spike is at 4 grams. Do you know the composition of the cannabis that you use? And for the vast majority, it was the blue is THC predominant. Is your use of cannabis adult use? Again, the bluish purple there, 6% purely medical and 38% both. Use patterns, I can't even read the captions. Again, treated for dependency or addiction, the majority of the CHS patients. And have you ever had to stop for a health reason? Again, the majority of the patients. Withdrawal, 3/4 of the controls had never had withdrawal. These were symptoms of withdrawal, anxiety, difficulty with sleep, the things that you would imagine in any other context. Periodic nausea and vomiting, and this is how often it happened. For many people, it was daily, weekly, etc. That figure was 0 for controls. Hospitalizations for nausea, again, the vast majority of the CHS patients, that figure was also 0 for the controls. And abdominal pain, same thing. Everyone of the CHS patients had severe abdominal pain and none of the controls. How often? Again, varying from daily to weekly or episodically. And let's just go ahead here. Episodes lasting anywhere from days to months at a time. It would really depend on whether people were continuing to use cannabis. Did the condition improve after cessation of cannabis usage? The vast majority, yes. After a period of abstinence, did the symptoms resume? Again, vast majority of that was true. And how long it took really was a function of cannabis usage. I can just say in general that when people start back, often they do so gingerly and may not have a problem. The problem will occur with dose escalation or at a point that they develop tolerance again. This one was interesting. Do you have an opinion as to the cause of cannabinoid hyperemesis syndrome? A couple of people thought it might be genetic. A couple of people didn't think that they believed in the diagnosis. 6% thought it was related to neem or pesticides. This is a chart on the demographic comparison. In both instances, there were more women than men. I don't think that's typical of the demographics in the actual population. It's just that women are more patient to fill out a long questionnaire and engage in a study. You see again, smoking habit, 86% were daily consumers in CHS and 70% in the control subjects. The big difference came in symptoms of abdominal pain, nausea, etc. So high figures for CHS and 0 for the controls. This thing is hesitant. Now again, this may be hard to read, but we looked specifically at a number of different genes, and we'll go into each of these in detail. But bottom line is there were 5 genes where there were mutations in the CHS patients that were statistically significantly different than the controls that didn't have CHS. The first hypothesized gene was CNR1 that encodes for the CB1 receptor where THC works. Now, in prior studies, there have been SNPs, single nucleotide polymorphisms, that were associated with cannabis usage, but we didn't see that in the CHS patients. Now, this is an important point of distinction because there is this thing called cyclic vomiting syndrome that is distinct from CHS, sounds alike. This is a form fruste of migraine. It often will begin in a child who has episodes of vomiting for no apparent reason, has a family history of migraine, and only when they're older, teen or even adult, will they develop more classic hemicranial pain, nausea, vomiting, and sensitivity of the eyes to light. So this test could form a distinction between CVS, cyclic vomiting syndrome, where cannabis helps, and CHS, where cannabis hurts. And there was, unfortunately, gastroenterology just published this opinion piece that made me crazy. Bonnie sent it to me, and she'll tell you what my reaction was. But they conflated CHS with CVS, saying they're subsets of one another or something. And they said it right here. CHS is a subtype of cyclic vomiting syndrome. This is a really dangerous and inaccurate statement. My letter to the editor has been submitted. We'll see if they bother to print it. Okay, so one theory was wrong, but still helpful. We didn't know anything about this one. This wasn't something we hypothesized. But this is COMT, catechol-methyltransferase gene, that breaks down dopamine. So there was a mutation on this gene in 57% of the CHS patients and only 10% of controls. You can see the p-value was significant. When there's a loss of function in this gene, it leads to dopamine excess, which can lead to compulsive behavior like gambling, sex addiction, or substance use. This particular mutation has also been associated with depression, rumination behavior, and alcoholism. So these are risk factors for the same population. And we've come to know a lot of patients who are affected, and they tend to have other substance abuse problems. It's also been associated with impulsivity, attention deficit, obsessive compulsive disorder, anxiety, and psychosis. So again, risk factors. One of the genes we did hypothesize as being involved was in fact the case. This is TRPV1 for that receptor. This mutation was in 71.5% of the CHS patients and only 30% of controls. TRPV1 does a lot of different stuff. Is it present in the gut? It's present in the brain. It mediates long-term depression in the hippocampus. It controls glutamate release in the solitary tract that affects gut motility and secretion. In a prior study, no mutations on this gene were seen in cannabis dependency, but they may not have been dealing with CHS patients. This was a new mutation that wasn't previously listed in the databases, but this really suggests a linkage to mood and the gut phenomena of CHS, as well as the hot water bathing, because that will stimulate TRPV1. Also explains why capsaicin on the skin will help. The other one that we hypothesized was, again, metabolic enzymes for THC. So CYP2C9, as we heard from Bonnie yesterday, is the main enzyme that breaks down THC. And in this instance, there was a homozygous mutation, two copies, that was seen in almost half of the CHS patients and only 10% of controls. So this breaks down a bunch of other things, including arachidonic acid, the precursor to anandamide. When this enzyme is not functioning properly, it could lead to THC accumulation and maybe kick it into that range where it's pro-emetic rather than anti-emetic. It's also possible that because the enzyme is screwy, that it could make abnormal metabolites that could be toxic. Previously, there was one case report of a mutation on CYP C19 along with 2C9 And that patient had CHS, also dependency and a personality disorder. Next, we found another dopamine gene, and this is the one that codes for the D2 dopamine receptor that's the target of most antipsychotic drugs. So 61% of the CHS patients had the mutation and only 20% of the controls. Stimulants of the DRD2 are pro-emetic and also affect gut motility, so this fits well as well. Again, depression and anxiety go along with this mutation. Also has been associated with cigarette addiction, Tourette syndrome, and chronic pain. The fact that we've got two genes affecting dopamine metabolism really helps explain the symptoms of CHS and also the psychiatric sequelae that seem to accompany it. And the last one was, again, something we hadn't predicted, the ABCA1 ATP binding cassette transporter. Again, a homozygous mutation, 2 copies, in 68% of CHS and only 20% of controls. This is a gene affecting cholesterol and phospholipid balance. It's also associated with ApoE accumulation and A-beta deposition in Alzheimer's disease. So having 2 copies of this would place people at risk for a bunch of things, including dementia later in life, also coronary artery disease and type 2 diabetes. Polymorphisms in a closely related gene were also associated with cannabis dependency. So, conclusions. We found 5 mutations with plausible etiologic roles in the phenomenology of cannabinoid hyperemesis syndrome that were statistically significantly different from high-volume cannabis users that didn't have the problems. We feel that this battery represents a screening test that could reduce costs and fruitless searches for other causes of this. I'll just read this from the paper. Cannabinoid hyperemesis syndrome can contemporaneously be conceived of not as a functional gastrointestinal disorder, but rather as a manifestation of gene-environment interaction in a rare genetic disease unmasked by a toxic reaction to excessive THC exposure. These are links. We have a website, what-is-chs.com, whatischs.com, where there's more information for caregivers or patients, also a link to the test if you would want to order this for someone. And we have 9 seconds. Thank you.